Okay, Miriam, I think we'll start.
Okay.
Well, I'll tell you what, I'd like to introduce myself briefly for anyone who doesn't know me, although hopefully all you registrants do. My name is Eric Igluski. I'm the social worker and the vice president of clinical services here at the Mary Gooley Center here in Rochester, New York. And I appreciate folks joining us today for this very important session that is hosted by the Mary Gooley Center, but sponsored and provided by the Hemophilia Federation of America. So without further ado, I'd like to introduce our special guest expert speaker, Miriam Goldstein. I'd like to think as an old friend of mine at this point in the community, and someone I'm proud to have seen shine brightly in many different capacities in different areas for the bleeding disorders community nationally. Miriam lives in Arlington, Virginia, and she's a mother of 2 adult sons with hemophilia. Miriam is the policy director and principal legal counsel at the Hemophilia Federation of America, where her work includes monitoring and analyzing federal legislation and regulations impacting patient access to care, insurance, Medicaid, and Medicare issues, blood safety, and more. Before joining HFA, Miriam worked as a lawyer with the federal government and volunteered for many years with her local Hemophilia Association and the Committee of 10,000. I'm very grateful that Miriam would choose to spend a little bit of her Saturday afternoon with us, and I'm going to let Miriam now speak about this complicated insurance landscape that we all deal with in this day and age.
Thank you so much, Eric, and thank you so much for those very kind words. It's a great pleasure to be here with you. I wish I could be in Rochester in person, as I've gotten to do in other years. But this is the next best thing, and this is what we do in 2020. So I wanted to talk about staying covered and about health insurance trends in 2020. And I would love it, Eric, if you would chime in as appropriate, because we're a small group, and you know, especially on New York specific issues, you will have so much more expertise than I have, but I will present kind of the national overview, both where we are today in terms of insurance, what people can be thinking about as we enter the open enrollment period for the coming year, and then trends on the horizon. So just a quick word about HFA. HFA is Hemophilia Federation of America. We celebrated our 25th anniversary last year. We are a national nonprofit organization that assists, educates, and advocates for individuals and families with bleeding disorders. We are grassroots only. We have a dedicated staff. We have wonderful publications and programs. But the thing to know about HFA is that advocacy is at our heart and at the heart of everything we do. So like I said, today we'll talk about trends in private insurance, because those overall national trends affect, trickle down and affect each of us. And obviously one of the big curves that 2020 has thrown at us is COVID-19. So we'll talk a little bit about how the pandemic is affecting insurance and options for people who may be facing coverage loss because of the pandemic and its economic fallout. We'll talk about some health insurance basics, because health insurance is really complicated. It is dry. It is convoluted, and yet it is so important. And so having that refresher might be helpful, just refresher on the basic concepts, basic vocabulary, because that will help set you up for success as you're looking towards making your choices for the coming year. We'll talk about some insurance company practices of concern that act as barriers to care and what HFA is doing about it, how that informs our advocacy agenda. And we'll talk about some big picture changes on the horizon. So as an overview, the 2020 coverage landscape, as everyone knows, there is so much economic upheaval and financial hardship due to COVID right now. And unfortunately, that is causing widespread losses of jobs. And when people lose jobs, often they also lose insurance, or they face difficulty in paying for care. It means that Medicaid enrollment is increasing around the country, which is wonderful. That's what the Medicaid program is supposed to do. It's supposed to be there to provide coverage in these times of hardship. But it means that states are facing budgetary crunches as their Medicaid enrollment grows. Private payers, and that means insurance companies, or it means employers who offer insurance to their employees, are trying to control costs because the costs of healthcare are going up and up. And unfortunately, they often try to control costs by putting obstacles in the way of consumers to access services and care that they need. And for a community like ours that is so reliant on access to good healthcare, that's a really big problem. And it's almost putting the burden on the least appropriate place. Less of a problem in New York State, which is nice for you guys, than it is in other states where I give this presentation. There is a proliferation of cheaper but skimpier health plan options that are sometimes misleadingly marketed and do not provide the coverage that people with bleeding disorders need. It's a real situation of buyer beware. And as I said, in New York State, you were lucky because your state government provides some extra layers of protection, consumer protection, that some other states don't provide. And finally, in terms of those big picture on the horizon events, there's litigation over the Affordable Care Act, whether it will survive. And there are upcoming national elections, and that all of that creates some substantial uncertainty about what will happen in health insurance and healthcare over the coming year. So let's talk briefly about trends in private insurance. And there's some charts and graphs in here that I will not go into detail. I'm going to go whizzing right by them, but I'm happy to share this presentation if anyone wants to look at them more closely. So health spending is rising. I think we all know that. This just shows exactly how sharply it is rising. Premiums for job-based coverage are increasing. So this is people who are fortunate enough to have coverage through their jobs and can't see the years, but this basically covers a 20-year period with the farther past at the top, the present at the bottom. The dark blue shows the share that employers pay, and the light blue shows the shares that might be deducted from your paycheck for your share of the premium. And the premiums for a family policy in 2019, the combined employer and employee share, $20,000 last year. A growing number of people are underinsured, and that means that when you take what they have to pay in premiums and then what they have to pay in cost sharing to actually use their insurance, they have to spend more than 10% of their income. And so that's a hefty financial burden on families, and underinsurance is a problem in the for people who buy ACA plans, who buy individual plans on the marketplace. That's the orange line, but it's also a problem for people who get insurance through their jobs. And the share of Americans with job-based health insurance is decreasing. This is before COVID. And it is a concern because the American health insurance system is kind of premised on the idea that you will get health insurance from your job. And increasingly, that is not the situation for very many people. So as I said, that erosion of job-based health insurance is only accelerated due to COVID. This was a headline from the New York Times this summer, saying 5.4 million Americans have lost health insurance because of the COVID economic fallout. And that number has only increased since the summer, and different analysts expect it to go as high as 10 or 20 million people impacted. So I did want to let you know, if you are in that situation, if you are facing the loss of coverage because you have lost your job, we have resources for you. This is just an infographic to present it sort of as in as punchy a form as possible. But you know, Medicaid might be the one place you look. Subsidized coverage in the ACA individual market, or COBRA coverage, which is where you pay to take over paying the entire premium for your job-based health plan and continue on the health plan you were on before you lost your job. HFA and NHF worked to create some resources as COVID hit, to provide a little more detail around that infographic. And so you can find this guide on the HFA website, and you can also find it on the NHF website. I'm just not as familiar with their website as with ours, but it provides kind of a roadmap, you know, how to think about your options, where to look first, and you can always contact HFA, and I know you can also always contact my colleagues at NHF, and we will be very happy to talk to you over the phone and maybe provide a little more tailored advice. So I said that we would do a bit of a refresher, we're changing gears here, on Health Insurance 101, just because this is convoluted. It doesn't come naturally to anyone. And so just going over the basics can be helpful. So I mentioned that job-based coverage is kind of the foundation of the American system. But even in job-based coverage, there's different kinds. There's fully insured versus self-insured plans. Fully insured is where an insurance company pays the claims and your premium covers all the risks and costs and administration of the plan. It can be very hard to tell whether you're in a fully insured or a self-insured plan, because in both cases, you in your wallet probably have a card that says Blue Cross or Aetna or United Healthcare. The difference is with a self-insured plan, that insurance company is administering the plan on behalf of your employer. And in the end, your employer is on the hook for all the costs of your care. And this is typically the system that is used by large employers. So if you work for Home Depot or Wells Fargo or IBM, you know, or Safeway, any big company like that, you are most likely in a self-insured plan. Self-insured, whether you're in a fully insured or self-insured plan, also determines where you take a complaint if you're not getting coverage for something. So do you go to the health insurance company with a fully insured plan, or do you go to your HR department for a self-insured plan? There are basic types of private plans, and that is true whether you're in a fully insured or a self-insured. They range from health maintenance organizations to preferred provider organizations. The difference there is really how much choice you have and how broad of a network do you have to go for care, and how easy is it to go outside of care. High deductible health plans linked to a health savings account are a specific kind of plan where you have to pay quite a lot out of pocket before your plan starts kicking in anything towards your medical costs. But if it's linked to a health savings account, your employer might be funding a separate health savings account that will help you while you're in that deductible phase. So I've already started using some terms and I haven't defined them yet. So now it's time to define them. Premium, that is the amount that you pay just to get the health insurance policy. Think of it as almost a membership fee. It is what you pay right off the bat to be able to say, I have health insurance. Deductible is an amount that you have to pay out of pocket before the health plan kicks in. And the deductible might not apply to all services. So in fact, for most people, primary care, a visit, not a comprehensive care visit with your HTC, but a primary care visit with your general practitioner is covered before the deductible. Copay is a fixed dollar amount that you pay out of pocket. And again, this is in addition to the premium. Copay is something you might pay every time you have a doctor's visit or for prescription drugs. Coinsurance is similarly a percentage amount, dollar amount that you pay for using services. And here the problem is that it's not a fixed amount, it is a percentage amount. And it is very common with specialty drugs and clotting factor and other bleeding disorders, medications. And because those are costly medications, setting your out-of-pocket amount by a percentage rather than a flat fee can mount up very quickly. So there are limits by federal law on how much you have to pay in a given year out of pocket. These are really high limits. You might look at them and say, how could I possibly pay $8,550 or $17,000 from my family on top of my premiums, on top of living expenses? And that is absolutely right. These are very high limits. The problem is that there used to be no limits before the Affordable Care Act. So when you think about those coinsurance amounts, when you think about paying a percentage of, say, your clotting factor costs, if there's no limits, you could be on the hook for even more than this. So these are the good limits. We'll talk about the Affordable Care Act, and I like to talk about the bad caps and the good caps. These are the good caps. They prevent you from unlimited financial exposure, but they're still really high. Now, what counts towards that out-of-pocket maximum? Premiums don't. Remember, that's just your cost of getting in the door. But deductibles, copays, coinsurance, and qualified health expenses for essential health benefits. So if you see an acupuncturist, that may not count towards your maximum out of pocket. It depends on if your plan considers that an essential health benefit. But copays and coinsurance for your prescription medications, for office visits, those will count towards your out-of-pocket maximum. I jumped ahead here. These are the things that don't count towards your out-of-pocket maximum, your premiums. That is your cost to get in the door. If you go out of network and you to an out-of-network provider, they can bill you more than an in-network provider would bill you, and they can bill you actually up to the full rack rate, which is a problem. It's something called surprise billing or balance billing. Unfortunately, that's a problem in and of itself, and it also doesn't count towards the limits on your out-of-pocket spending. You may have heard about metal tiers with plans, with bronze plans, silver plans, and gold plans. And what that means is the percentage of your medical costs, taking you as a typical consumer, that you can expect your plan to cover. And so a gold plan is expected to cover more of your total costs and leave you with less out-of-pocket expenses. A bronze plan leaves you more exposed to the out-of-pocket expenses. And so this just kind of breaks it down for you. Bronze plans, but in the marketplace by law, have it's called an actuarial value. They're supposed to cover 60% of the cost of medical care for a typical consumer. Silver 70%, gold 80%, and platinum 90%. And you can see that some of the employer plans, so non-marketplace plans, rate at the upper end of those ranges.
Miriam, can I interrupt with a quick
please.
question? A lot of the patients and families I work with who are navigating the marketplace or navigating high deductible plans are are very much noticing, the very generous pharmaceutical copay programs that they offer. Sometimes that might guide them, for better or worse, to take a plan with a higher out of pocket. Is there risks involved in that, or is that strategic, that's an issue that comes up a lot.
It's a great question, and it's really hard to give one-size-fits-all advice, as I'm sure you have encountered. I'll talk about a little later when we talk about the barriers to care. One of the barriers to care is a practice that some health plans are adopting, where they're not allowing that manufacturer copay assistance to count towards people's out-of-pocket maximums. And so then it is a risk. But if you can be confident that you can make full use of that manufacturer assistance, then you can be strategic. And it makes sense to go for the lower premiums, and knowing that your out-of-pocket costs will be covered by the manufacturer assistance. You have to read the plan, and you have to read it carefully, and boy, are those things long and dull and convoluted. And then you have to make phone calls, because you can't just rely on reading the plan. You have to talk to your great and expert HTC staff like you, where the HTC social worker may have experience with the plans in your area and have specific experience with those plans and know where the pitfalls are. It is labor intensive. It involves a lot of phone calls. It involves, please take notes and keep records for yourself as you make these phone calls. So the answer is all of the above. It might be strategic to do that. You just have to put in a lot of homework.
No. And along those lines, and thank you. That was a very thoughtful response, and one that I mirror with my consumers as well, because there are certainly risks involved, and it's a buyer beware situation. Before we go any further, another question that's popped up along this process is you had talked about fully insured and self-insured. Are there any differences, it was asked, between the ACA protections between those two, or do both buckets get equally protected with those protections?
They both get equally protected under the ACA. So the ACA required that both types of plans have an internal review process if you have a difference of opinion or you're unhappy that something isn't being covered. And they both have to have an external review process. It's just you'll go different places for those appeals depending on what kind of plan you're in. There is also a shrinking number of grandfathered plans, and I do not know off the top of my head if there are any in New York. Those plans, we just marked the 10th birthday of the ACA. Those plans should have gone away by now, but they've sort of been grandfathered along, and they do not have to meet ACA standards. I think it's very unlikely that someone with a bleeding disorder is in one of those, because they do not offer the protections that people in this community really need.
As a social worker, I appreciate you referencing that, because you're right. It's great that we're celebrating that 10-year birthday, because you're right. In hindsight, it was quite a bear for me to help people navigate, because there seem to be these potholes through these grandfathered plans, and that hasn't come up as much recently. So,
yeah.
It's good news.
No, it was, we actually had a bunch of patient advocacy groups had an ACA 10th year birthday party in Washington, D.C. in March. I think it may have been the last in-person thing I went to. Just to remind our friends in Congress of the important gains that the ACA achieved for anyone with a pre-existing condition, anyone relying on Medicaid, and we'll talk about that at the end here.
Sorry for the interruption. Keep going.
No,
Do
no,
it.
thank you. I love it. It makes it more conversational. It's much more interesting than hearing me drone on.
You're doing a fantastic job. We appreciate your gifts.
So thank you. So we'll talk about, because it is the fall, and fall is typically when open enrollment is, this is a great time to talk about getting coverage, sort of when, now, how, and what to consider. So open enrollment for employer plans is typically once a year, and it's often in the fall or winter. They can make their own rules. For ACA marketplace plans, it is November 1 to December 15th in most states. Some states that run their own marketplaces, like New York, can adopt a longer open enrollment period. For Medicare plans, October 15th, so that is coming up really soon, to December 7th, and those dates are the same every year. There's also something called special enrollment periods, and those are triggered by major life events. So if you have lost your job, if you have undergone a divorce and the health insurance policy was in the name of your divorced spouse, death of the policyholder, birth of a child, adoption of a child, moving out of state, things like that. New York State, because of COVID, has actually held I don't know whether to call it a special enrollment period or an open enrollment period, but they have made it available, I think now through the end of the year. They kept extending it, which is appropriate because people are still experiencing those economic impacts. So you really have to make your insurance choices during open enrollment, because otherwise you are locked out unless you experience one of these major life events. And here they are again. We already kind of talked about most of these. So Eric and I started talking about this. What do you do? How do you evaluate your insurance choices if you are fortunate enough to be presented with choices? One thing I have to emphasize, and I bet you do this, Eric, with your patients, is don't just automatically renew for the coming year. Make sure you review your policy and look for any major changes, because there could be changes that make it not work for you. Ask for help. Your HTC has phenomenal staff. As I said, your national organizations stand willing to help. We love to hear from you, but your local HTC is going to know at a much more granular level the ins and outs of the plans that are available in your area. Don't wait till the last minute, and I think I already said this. Call. And with bleeding disorders and with the products that are so essential to our care, the first person you get on the phone is not going to know the answer. This is where you have to make yourself a pest, and it is hard work. And no one likes to be that person that's saying, I think I may need to talk to someone else. I think you may not have the answers I need. So asking for someone who deals with specialty pharmacy or specialty pharmacy reimbursement, those are the types of words that are likely to get you to the person who will have the answers when you make these phone calls. So what are your major sources? From your employer, if you are fortunate enough to have insurance offered through your job. From the individual market, the marketplace, healthcare.gov. In New York, it's got another name, but anywhere you are, if you enter healthcare.gov, it will redirect you to the right place. And in New York, it will redirect you to the New York State marketplace. I can say that keeping offspring on a parent's plan till age 26 has been just a key thing for my family. There's Medicaid, there's CHIP for families who earn too much for Medicaid but need coverage for their children. The New York State Basic Health Plan. which is something created by the ACA. There are only 2 states that have adopted a basic health plan, and it's available to people who earn too much for Medicaid, but for whom paying the prices in the marketplace would be a real burden. And Eric, I'd love to toss it to you to talk about anything more about the basic health plan. Or the Essential Health Plan is the name in New York.
Exactly. It's the Essential Health Plan. It's very easy to apply for on the New York State of Health.gov website. That's our marketplace here in New York. And again, it's a social worker's best friend is what it is, because it really has helped. It's been so helpful to our consumers who, like you just said so eloquently, Miriam, who sort of fall between the cracks, who just could never afford even a silver plan for the marketplace, but make a little too much for Medicaid. So it's these typically our young men who maybe aged out of their parents' insurance, maybe aren't making quite enough to pay for the marketplace plans otherwise. And what's great about it is it covers things beautifully, almost as comprehensively as Medicaid, but with a very little out-of-pocket costs. And for like the example I just gave of maybe the young man who maybe aged out, who doesn't have a lot of dependents, he'd be making about $25,000 a year to qualify or less, and have very little premium, and it's just a great program.
Yeah, and I think the other category of people, so as you said, I think it's available to people making up to 200% of the federal poverty level, or about $25,000 for an individual. Exactly. It's also available to immigrants with legal status who may not have the residency requirement years yet to qualify for Medicaid. I believe that's the case in New York. And so that's another really important source of coverage. So then just rounding this off, COBRA, which is that program to continue your employer-based coverage if you have lost your job. COBRA is very expensive because you take over the employer share of the premium as well as your own share of the premium. The thing is, for people in our community, at this point in the year, if you have lost your job, you don't qualify for Medicaid, you need to continue coverage, COBRA may actually make sense despite the high price tag, because you have probably already met your out-of-pocket requirements. And it allows you, and if you went to the marketplace, you would have to start all over again with a new deductible and new out-of-pocket requirements. And then the whole issue of whether you can keep your existing network of providers, including specialty pharmacy and doctors and all that. So COBRA is a pricey option, but oddly enough, for some people in our community, it may sometimes be the right option.
Miriam, that's an exceptional point. I have to admit, the last several years, I thought maybe COBRA was going out of style, because most of my my patients and families in those situations have shifted to the marketplace. But that's an interesting point you just made about maybe it might be worth the cost to stay the course because of those out-of-pocket maximums being met and whatnot. That's part of the equation I hadn't thought of.
Yeah, it's, math is required. It was not my favorite subject in high school, and didn't take much of it in college. And so this stuff is not easy, but there are resources. There are people who can help you with figuring this out. So marketplace plans. Most people who buy plans on the marketplace get assistance with their premiums. That is key. Please do not be put off if you go to healthcare.gov, if you go to New York State, I'm sorry, it's whatever the New York State marketplace is, and you put in your area, and it will generate a list of plans, and you'll look at the premiums and your eyes might pop. But if your income is under 400% of the federal poverty level, which is now, so I'm trying to remember, so roughly $50,000 for an individual, $100,000 for a family of 4. you are eligible for tax credits to help pay those premiums. And so, so you can't go by your first gut reaction to those premiums. You have to keep kind of plugging in the numbers. Then if your income is between 100% and 250% of the federal poverty level, you may be eligible for assistance with your out-of-pocket spending as well. Now, because of the essential health plan in New York, this is less of an issue in New York than in other states, because if you're under that 200%, you're going to go to the essential health plan and have very little out-of-pocket expenditures. So don't automatically assume that the plan with the lowest premiums will make the most financial sense for you. You have to think about your out-of-pocket spending. And this gets back to the question that Eric raised. You know, can you count on the the manufacturer copay assistance? Maybe you can, and then you can go for a lower premium and higher out-of-pocket. But you have to make sure that you can take full advantage of those manufacturer copay assistance programs. You have to look for hidden obstacles and that stand in your way of making good use of those programs. If you are buying insurance on the individual market, again, please and healthcare.gov and the New York State website will automatically figure this in. If you are entitled to tax credits to help with the premiums, and if you're entitled to assistance with your out-of-pocket spending, you have to bring a lot of documentation and input a lot of data about yourself. But just understand that the list price may not be what you are charged in the end. There are financial resources for paying insurance costs, and Eric mentioned one that's really important to this community, which is those manufacturer copay assistance programs and coinsurance programs. There's also premium assistance from charities like PSI, and so that is another source of assistance that can help with that, getting in the door, paying those premiums. And then different types of health savings accounts that your employer may or may not contribute to. And so we're still talking about considerations and the homework, the extensive homework that you're going to have to do as you sign up for a health plan in open enrollment. And obviously one of the things you want to look at is, does your plan cover the providers who you want to see and need to see? Is your HTC or your other hematologist of choice in network? What about any other specialists that you see? Hospitals that you use? Will you have a choice of pharmacy provider? That's gotten a lot narrower in recent years. And what happens if you go out of network? So it's a lot, as I said, it's a lot of information to piece together and figure out what kind of whole what the whole picture looks like when you piece together all of these different factors. Very key, are your products covered? We always ask people to investigate whether their product is covered under the major medical benefit or the pharmacy benefit, and that is so hard to find out. Part of the reason it's important to find out is that most of these marketplace tools or online marketplace tools will have an online formulary where you can check if your product's covered. But the online tool only covers things that are covered on the pharmacy side. So that's another reason you have to make these phone calls and you have to make yourself a test. You may look at a marketplace plan and say, they don't cover any clotting factor at all. How can I sign up for this plan? And it might be covered on the major medical side. And so you have to call. I see you nodding, Eric. Are there other tips that you found have worked for people?
No, I was just nodding emphatically at that particular kind of spider web you just described, because
Yeah.
I think a lot of folks operate on the assumption of the pharmacy benefit, and that shock value. I've had many call me saying none of the drugs are covered, and that's not the case. I mean, it's the major medical, and again, you've given a couple nice plugs to the Friendly Neighborhood Social Worker, but I'll jump on that. And that, people don't need to do this alone. They can certainly reach out to their HTC social worker, and we can be advocates. And I've gone to, for folks who worked with the marketplace, I've accompanied with them two meetings with health insurance navigators to help them ask the right questions, because it can get overwhelming. So.
Yeah. And the navigators are a great resource. They are provided by the marketplace itself. But, remember, we're a small community, and so our concerns are, really important to us, but kind of niche. The navigators may not ever have counseled someone with a bleeding disorder and not even know, sort of where to begin. So having that expert assistance is wonderful.
I can't speak to what my colleagues do at other HGCs, but when I've young men or patients who are navigating the marketplace, I think a lot of the, sorry, I'm aging myself, but I'm still going to say it. A lot of the kids today are prone to just go online and apply that way. And that's very fine, but it's easy to, I can't speak of other states, but sometimes there's technical difficulties and glitches. Maybe I'm just old-fashioned, but I really recommend our patients connect with a navigator and bring me along, just as an advocate and as someone who can help translate, like you said, this really niche-y language that's unique to our very small community to this otherwise great expert who knows a lot about insurance.
That's wonderful. Really valuable service that you're providing. So I wanted to just touch on this. So, even once you have insurance, unfortunately, there can be bumps in the road. Insurance company practices that act as barriers to care. And these are some of them. Some of them are de facto. They're, how on earth do I pay these out-of-pocket costs? Some of them are insurance company practices. That's insurance companies creating narrow formularies and saying, we're not going to cover your product, or we're not going to cover your product, the product that your doctor thinks is best for you, until you try 1, 2, or 3 other products first and fail on them. It's a practice called step therapy. Or we're going to place the product, maybe the one that's best for you, on a higher tier with higher cost sharing. Now, again, in New York State, you have some state level protections that some other people would be very envious of, which is great. But unfortunately, this is the lay of the land. A lot of practices that are aimed at saving money, but they do so by making it hard for people to access the care they need. So I wanted to put out some other resources. As Eric said, there really is no substitute for making that in-person contact and asking the questions, but there are some resources where you can start your self-education on the HFA website and indeed on the NHF website. And if you do encounter one of these obstacles, you have your insurance and yet you cannot access the care you need because of insurance company policies that stand in your way, please let us know at HFA. We have something that is now in its 5th year called Project Calls, where we try to document those insurance company practices. We try to collect data and then use that as we talk to lawmakers, as we talk to payers, to try and make the insurance system work the way it's supposed to for people who need it. Project Calls, if you encounter one of these problems, which we hope you won't, You can call us, you can fill out the survey online. It is now a short survey. If you call us, you will get a trained social worker on the HFA side, and we keep your data very, confidential. And just to let you know, over the years, the Project Calls has been running. We get twice as many reports of problems that people have encountered in accessing their product as we do of problems in accessing their provider. And we consistently, over the years, in half the cases, people report that the insurance company practice that is causing them problems has caused them to delay care. And we know in bleeding disorders, delayed care can have really serious health consequences. So we take that to lawmakers and say, look, you have to put some constraints on insurance companies' use of these tactics because it is harming people's health and it's even backfiring. If you have delayed care, you have breakthrough bleeding, you have an emergency room visit, or you're using extra factor, that's not saving money for the insurance company in the long run. So please help us. Like I said, I hope you will not encounter these problems. And if you do, and you have the bandwidth and are willing to share your story with us, that helps us try and make a case for change. So just takeaways for the coming year. If you do not have insurance through your employer, start your search at New York State of Health.newyork.gov or healthcare.gov. It's easier to remember and it will direct you over to the New York website. Be an active participant and unfortunately put in all this hard work that you have wonderful resources here with your HTC staff being so willing to help out on your behalf. Make sure you understand if your options have changed from year to year. Do not just focus on the list price because there are sources of financial assistance that can help you afford your insurance. So that's where we stand now. And unfortunately, there are some threats on the horizon. And the big one is a lawsuit that is right now in front of the Supreme Court. I don't know if any of you have heard of it, but it is a lawsuit challenging the constitutionality of the Affordable Care Act. Most legal experts, and that's regardless of their political persuasion, actually think that the merit to the lawsuit is that there is very little merit to the lawsuit. It is on really shaky ground. And yet 2 federal courts have so far ruled against the Affordable Care Act and decided that it is unconstitutional either in whole or in part. And I'm a former lawyer, happy to geek out on the arguments with anyone who wants to ask during questions. But 2 things to know for right now. The case is on appeal to the Supreme Court. The Supreme Court will be hearing oral arguments on November 10th, 1 week after the election. And while the case is on appeal, despite these lower court rulings, the ACA remains in effect. Now, why is that important? I love this graphic, which came from Kaiser Health News. It says, obviously, the ACA has affected nearly all Americans in some way. We talked about how the ACA just turned 10 this year. And 10 years is sort of a simultaneously a blink of an eye, and it feels like forever. And so people now think that protections that were put in place by the ACA are baked in. People assume for granted that even if you have a pre-existing condition, you can get coverage and you won't be charged more because of your pre-existing condition, and the health plan can't deny you treatment for your pre-existing condition. That was not true before the ACA. The ACA provided Medicaid expansion, provided funding so that low-income adults, regardless of whether they have a disability, regardless of whether they have children, can get Medicaid coverage. That was not true before. The ACA created these marketplaces. The ACA also provided benefits for people in employer-sponsored health insurance. So I remember I said something about bad caps and good caps. Pre-ACA, there were people who had annual or lifetime caps on how much their insurance would protect them. So maybe the insurance company would only pay out $100,000 in benefits in a year or $1 million over a lifetime. In our community, that doesn't go nearly far enough. And the ACA said across the board, insurance companies cannot put those kind of caps on benefits. The ACA allowed or said plans have to cover kids age 26. The ACA said plans had to cover essential health benefits. So in the marketplace, so access to maternity benefits, to prescription drugs, to specialist care, those were not routinely covered by individual health insurance plans before the ACA, and now they are required as essential health benefits. So if the case goes wrong, and this is actually from last summer, I think, so the numbers are higher now. 21 million people could lose their health insurance altogether. That's people covered by Medicaid expansion and people who get their coverage in the ACA marketplaces. 133 million people across the US have pre-existing medical conditions. They're not all as serious as bleeding disorders, but more enough to get people barred from insurance in the past or have to pay more. So about 52 million people have conditions serious enough to be denied coverage outright, and you can bet bleeding disorders fall in that category. 171 million Americans could face a return of annual or lifetime caps, the bad caps. You've exhausted your health insurance benefits and have to look elsewhere. And 2 million adults who are under 26 could, the health plans could decide to stop covering them. So like I said, those are pre-COVID numbers. Those numbers are, if anything, more extreme now because people are migrating to Medicaid and to the marketplace with COVID and COVID-related economic difficulties. So all that means healthcare is going to be front and center in the November election, and now even more so with Justice Ruth Bader Ginsburg's death last night. And with a pandemic going on, so people are very concerned about staying healthy and being able to pay for their care. And so what does that mean? It means register to vote. Please, I cannot tell you how to vote, but please make sure you're registered and please do the research and make sure to vote on the things that are important to you. And so with that, I am going to end the slideshow, and I don't know if there are questions.
Actually, Miriam, we addressed all the questions as we went. So we got them all tackled. I have to tell you, you did a fantastic job covering so much ground and really taking some complicated concepts and breaking them down. Although, between you and me, it sort of bummed me out at the end there. It's heavy to think about, just as a person who's been serving the bleeding disorder community myself for 10 years, and to know I understand that the ACA is politically charged and maybe provokes people in different directions depending upon where they may be philosophically or politically, but as a provider, I have to tell you, it's made a huge amount of difference in the lives of our patients. And I dread the thought of going back to our having to help patients deal with meeting annual caps by March because their medicine's so expensive, or not getting their medicine at all because of pre-existing condition. I'm going to hold my breath and see what comes ahead, but I think it'll be months ahead before we know, right?
It will be because fool's errand to try and predict anything about what's happening with the Supreme Court right now. But as I say, the case won't be argued until a week after the election, and then it can, the justices typically issue an opinion before their term ends in summer of 2021, unless they were to decide that they needed to have it re-argued for some reason. And there's an election, and who knows what that will bring. So it is an unsettled time, and I hate to end.
It is unsettling, but I guess to spin it in a hopeful way, I'm incredibly proud to be a part of the bleeding disorders community as a provider, because it's a very empowered community, and I think that folks with hemophilia and von Willebrand's and rare bleeding disorders can say there's a feather in their cap, and that their stories helped the ACA get passed. Their stories made a difference. And New York State has a very empowered bleeding disorders coalition. HFA and NHF have wonderful and I think very powerful advocacy days, both in the state and certainly on the national level. So we're not done fighting yet. And
Exactly.
this community will continue to fight, I'm sure of it, whichever way the wind blows. So,
Exactly.
So on that note, I see we've come to about an hour here, and I just want to thank you again, Miriam. You're extraordinary. I appreciate you sharing your time with us and your expertise. My understanding is this program, this session will be recorded, and for anyone who missed it, I'm thankful that they can catch it at a later date.
Well, thank you so much for having me, and I really enjoyed our back and forth and having this be a conversation. It's really marvelous.
Let's do it again sometime, okay, Miriam?
Yes, yes.
Well, on that note, I just want to wish everyone well, and we'll see you next time.
Okay, take care.
Bye-bye.
Bye.